Good afternoon, everybody. Unfortunately, the traumatic glaucoma, the file not open, so we'll give the lecture which is supposed to be given next week, which is optic nerve evaluation. As we know, all of you, that glaucoma as a disease, it's optic nerve neuropathy manifested by visual field change, and IOP is variable. I remember in the past, maybe 40 years ago, when we were medical student, the definition of glaucoma, when they ask us, increased intraocular pressure. Unfortunately, still the medical student, when we ask them what is the definition of glaucoma, they mention increased intraocular pressure. So the glaucoma is characterized by the glaucoma, as we know, is multifactorial disease, and optic nerve is our target. As I ask you, what is the definition of tonsillitis? You will tell me inflammation of the tonsil. What is the definition of hepatitis? Inflammation of the liver. So when I ask what is glaucoma, so don't mention increased intraocular pressure, because IOP is variable. You may get a lot of cases of glaucoma with normal range of pressure. It is written even American Academy that 50% of open angle glaucoma, they are presented by pressure less than 21. So if it is like that, you may lose a lot of cases of glaucoma in your practice, especially if you concentrate mainly in intraocular pressure. There is many centers in which the patient, when he enters the clinic, they put the IOP in the checklist. And when you see the IOP taken by air buff or other equipment, it may be not the real IOP. And this is the problem if you depend on IOP in diagnosis of glaucoma. And the aim of our lecture today is to concentrate on when you look to optic disc. Don't miss to examine the optic disc in your practice, even if you are not a glaucoma man. So what happened in glaucoma? As usual, video sometimes is not working. It is very important to concentrate in quality of life of glaucoma patient. And in practice, exactly, the glaucoma patient may not complain of any visual field defect as the people think. You can see in other slide, unfortunately it not work again. So maybe some blind spots will be in front of patient of glaucoma, not as people think that there will be visual field defect in front of him. And it is very important to differentiate between the structure loss and the function loss. What is structure loss? Is the way you examine the optic disc, you can see, and you can see it in, like example, OCT. In functional loss, you can see it in visual field examination. Usually the structure loss precedes the function loss. What mean by that? You may have a glaucoma patient and you will see the normal visual field is normal. Visual field deterioration will occur when there is a lot of destruction of retinal ganglion cell layer, up to 25% of the cells. So the functional loss usually come when? Late. So what in our hand now to have early diagnosis of glaucoma is to look carefully for the optic nerve and check the structural loss. You can see in this slide you can see in this slide, unfortunately this one also is not working good. You can see the progression of visual field occur after 3-4 years in this slide. But definitely the structure loss is seen in the first time or first year you see the patient. So better to concentrate in evaluation of your optic disc. So what is the problem actually in diagnosis of glaucoma? Intraocular pressure, you look for it. You look for nerve fiber layer analysis, then optic nerve head assessment, and usually you do visual field or octopus visual field or Humphrey, whatever you have. So what is the problem actual? There is limitation of intraocular pressure. Why there is limitation of intraocular pressure? in diagnosis of glaucoma. Number one, because the corneal thickness affect. So maybe the patient has high corneal thickness and the pressure will take in very high, false high, and you will diagnose that the patient has glaucoma. Number two, the IOP fluctuate, which is very important, what we call it variable diurnal variation. The patient, he will come to you in a clinic afternoon, you have only clinic afternoon, but usually the pressure is high in the morning, early morning. So if you have a doubt of patient for his IOP, you may bring the patient twice in one day to check the diurnal variation. Also, there is some cases with glaucoma with normal pressure, what we call it normal tension glaucoma. So what about the limitation of visual field? It is subjective, not objective, high variability, and poor sensitivity. So if you depend on visual field only, you may misdiagnose glaucoma. If you depend on intraocular pressure also only, you may misdiagnose of glaucoma. So 50% of optic nerve fiber loss prior to visual field defect, and by time there is 5 decibel loss when there is corresponding 25 loss of retinal ganglion cell. So to have a real visual field defect, you may have time until it occurs. Early glaucoma can be missed if the clinician rely only in visual field and intraocular pressure. And as we know, because glaucoma is optic nerve neuropathy, and this is the aim of our lecture today, to look carefully to the optic nerve. I know you may examine fast the patient 2020, intraocular pressure is normal, but you should concentrate in the optic nerve. You may find any signs of early glaucoma. There is what we call it 5 rules in diagnosis of glaucoma on optic nerve evaluation. So number 1, we look in the rim. Number 2, look to peripapillary region. Number 3, look to nerve fiber layer. Number 4, look to lamina cribrosa. And the number 5, look to optic disc hemorrhage. Some of these criteria are pathognomonic for glaucoma. This is what we will discuss. Some are not pathognomonic for glaucoma. But at least when you look to the optic nerve, look carefully for all these criteria. So when we look to the first rule, look to the scleral ring and the cup disc, cup border. But there is ring border and the cup border. Look here, this is the scleral ring. Let us go with it. This is the superior cup border. This is this clear ring, and this is the cup border ring. So there is superior rim, inferior rim, nasal rim, and temporal rim. And this what we apply, what we call it isn't rule. The rim is the reddish area away from the cup between the square ring and the cup border. And this rim, as you can see, the superior rim is more thinner than inferior, more than nasal, more than temporal, and this what we call it isn't rule. So isn't rule should be applied when you look to the optic disc. As we mentioned here, this is the cup border, this one is the cup border, and this is the ring border, and between them is the ring, is the rim, sorry. So the superior rim should be thicker than inferior, isn't. Thicker than nasal, thicker than temporal. This is the rule. So if this rule is broken, it doesn't mean it is glaucoma, but most likely you have suspicion of glaucoma. Sometimes definitely you have anomalous disc, which may mislead you to diagnosis of glaucoma. So this isn't a rule. This is the scleral ring, and this is the cup border ring. Between them is the tissue of the optic disc. So as we mentioned before, this is the rim width, is the distance between the scleral ring and the location where the vessel is bent. And very important here, look for the kink of the vessel, not the cupping alone. Because when you have kink, sometimes the kink occur in a pinkish area, not pale area. This we'll see later on. This is the isn't rule again. What about the color of the rim? Look here. What this arrow show you, this is the bending of the vessel in the cup area. Sometimes the bend, as I mentioned before, not necessary to be located in the pale area of the cup. What is the pallor, the cup? Cup is definition is the pallor area in center of optic disc. Pallor area. But when you are a glaucoma, you are not looking only to the pallor. You are looking mainly to kink of the vessel rather than to look for the pallor. You measure the cupping not related to the pale area, but mainly related to the kink of the vessel at that area. Look here, this is the kink of the vessel. And when you want to estimate the cup disc reach here, so you look between the upper and the lower kink, the longest distance. This is what we call it vertical cup disc ratio. You can measure also the horizontal cup disc ratio, the pale area, but look mainly to the kink of the vessel. So this is the vertical cup. This what come to you written exactly in a numerical number in OCT. He will mention to you vertical cup disc ratio, horizontal cup disc ratio, rim widths, average rim widths. So here if you look, the cupping here is equal to pallor, or pallor is more, or opposite. What do you think? The cupping almost equal to the pallor, is it? If the cup is equal to pallor, most likely, I cannot tell exactly, it is physiological cup. It is normal disc. If the pallor is equal, so you may have, طبعا it is mentioned that 2% of population, they have cup disc ratio more than 0.7. So if you get a physiological cup like that 0.7, we cannot mention this is glaucoma, but at least we can call it glaucoma suspect, and you should make regular investigation for this patient to rule out glaucoma, even if it is physiological cup. But if pallor is more than cupping, so most likely it is a neurological disease rather than glaucoma. If cupping is more than pallor, so most likely it is glaucoma disease. So this is most likely normal disc as we mentioned, but you cannot tell in the clinical practice. You know, طبعا definitely when you work you have some sort of medical legal issues, and you may miss a diagnosis of glaucoma because you don't do an investigation for this patient. This is physiological cup. We know that this is physiological cup, but you should do the investigation for this patient. As we know, OCT, visual field, intraocular pressure, all this should be measured at the same time. Then you can rule out that this is not a glaucoma disc. What about this disc? What do you think? There is cupping. Yes, there is cupping. There is pallor. Yes, who's more, cupping or pallor? Pallor is more. So the criteria of this disc is looks mainly pale disc, and the pallor exceeds the cupping area. Can be glaucoma? Yes, can be glaucoma. What is the problem? But we are talking about the rules, not the exception. The rules. طبعا this is my habit when I give lecture. I usually have water in my hand. Why I don't have water? We'll tell this later on. You know, Ali. You can see the pallor area, and you see the cup. Who is more? The pallor. When the pallor is more, so most likely this is a neurological problem rather than a glaucomatous optic neuropathy. طبعا we know optic neuropathy, there is a lot of causes, traumatic, infiltrative, viral, whatever you are. The most common cause of optic neuritis is glaucoma. So here pallor is more than cupping. What about this disc? Look here, this is the cupping. But the disc definitely has diffuse pallor. So pallor, when it is more than cupping, so most likely this is a neurological disease. And you should observe that I usually mention most likely. Maybe Dr. Malik will know this, especially in exam. The word most likely is important to mention in some cases. But I will show you some slides. You should not mention most likely. You will fail if you mention most likely. But take care of this word for a little time. This patient has pallor more than cupping, this disc, so most likely this is a neurological disc. What about here? طبعا here he measures the horizontal. He should measure the vertical because the vertical cup is longer than the horizontal. What about this area? This is what I mentioned before, that we are not looking to the area of pallor mainly, but we look when you measure the cup disc ratio, you didn't measure it up onto the pale area. You measure it up onto the kink of the, if you look here, there is nasal kink. Somebody will ask why you are looking for nasal. Sometimes the cupping of glaucoma is mainly in nasal rather than superior and inferior. This is nasal cupping, you can see. So the cupping here is bigger than what we are looking in the pallor. Is it? So most likely this is a glaucoma disc because the cup is more than the pale area. What about here? You can see the pale area. I think the slide is not not that clear for you. The kink of vessel is superior. And it looks again, if you look carefully to the kinking, maybe the slide in the TV is better. You can see the kink. So here the cupping is more than the pallor. Most likely this is a glaucoma again. So what about this area, this one? What do you think here? Very clear, huh? There is nasal completely shift to the vessels in the nasal area. There is nasal cupping. You can see inferior also that there is part of splinter hemorrhage. What about this one? What is this? This is what we call it notch. Notch may be up to the rim, may be not to the rim. When you look to this slide, the notch is up to. When the cupping reaches the cup border, we call it notch up to the rim. But sometimes the notch not reaching to the border itself, to scleral ring. So the cupping, the notch may be up to the ring, may be not reaching the rim. This is most likely. We should not mention most likely here. This is what I mentioned before. The word most likely when there is, it can be glaucoma or not glaucoma, but there is two pathognomonic signs to diagnose glaucoma in your examination optic disc. Number one is, number two, wrong. Who to mention beta zone? Wrong. She mentioned half answer of the question. We'll tell later on. Wrong. Half of the question, half of the answer. This is the answer. We will mention it. You mention it correctly, but if you get the patient and you measure beta zone, you tell this is glaucoma, this is wrong. But we'll show you how beta zone and peripapillary atrophy is important. So we have two pathognomonic signs. One we mention now, which is, so if you see a notch this is definitely glaucoma. So this is very important point to tell that notch is pathognomonic of glaucoma. And usually if I see notch, look for other important things. You turn the slit lamp to red free, you will see the nerve fiber layer very carefully, or by direct ophthalmoscope. So you should have some visual field defect, nerve fiber layer defect opposite to the area of notch. And look carefully for hemorrhage, splinter hemorrhage, hemorrhage in the disc itself or close to the disc. So the beta zone here again. What about this slide, this disc? You can see here the loss of nerve fiber layer opposite to the area of the cupping, vertical cup. And this is the notch. This is what I mean before. Not necessary to have the notch reach to the optic disc margin, to the scleral ring. So sometimes you have notch up to the rim and not reaching the rim. This is the second area which is important, which we'll call it peripapillary atrophy. There is two zones close to the optic disc. Usually you see it in a myopic disc. Before we are telling this is myopic disc because there is peripapillary atrophy. There is alpha zone and beta zone. Who is close to the disc? Who is far? Beta. علشان ما ننساها, should not forget, beta bait, your house is close. So beta zone is close to the optic disc. Alpha is the pigmented area away. يبقى there is one small area pigmented in the far periphery from the disc, and the one close is the beta zone. What is pathognomonic actually is not beta zone, as Mus'ab mentioned, in serial photography of optic disc, enlarged beta zone, not beta zone. So beta zone is correct, but if you mention this is not the correct answer, you should mention enlarged beta zone. طب how I will do enlarged beta zone? This is again important of clinical examination of optic disc away from visual field and intraocular pressure by doing, when the patient come, optic disc photography. Now we have octopus. I think in many places now you can get a picture for optic disc without dilating the pupil, non-mydriatic. You can take the photo, repeat it after 6 months, and you can check the size of beta zone. Look here, this is the alpha zone, the pigmented area. And this is the beta zone close to the optic disc. And this is the area when it increases by serial examinations for you in a patient every 6 months, indicate that this patient is definite glaucoma and there is progression also. What about this slide? You can see this is the alpha and this is the beta zone around all the optic disc, and there is very large cupping. What about looking of the retinal fiber? Any one of you look to any child by direct ophthalmoscope for the optic disc? Anyone try? For a child, I am not. What do you think when you look to the optic disc and nerve fiber layer in a child? You will find striation looks like white, looks like papilledema, especially if the child is hyperope. You will see carefully the nerve fiber layer, very bright. So look here to the nerve fiber layer. This is the bright area, and close to bright area there is dim area which you show optic nerve fiber layer atrophy. So it is easy for you to get nerve fiber layer from the first spot of examination? No, it is not easy. But when you look for nerve fiber layer, as I told you, make the red free, and also if you can detect an optic nerve, notching, follow the notch to the nerve fiber layer, you will get this area. How to know that there is atrophy? The vessels in this area usually became prominent vessel. The vessel is hidden in nerve fiber layer, but when it is prominent and this area looks little dark, it is nerve fiber layer atrophy. Sometimes it's difficult to see the nerve fiber layer atrophy if there is total cupping and all the area is diffuse atrophy of optic nerve of nerve fiber layer around the optic disc. Look here for this one, you can see the notch. Notch is seen or not? يا علي مش شغال، ده بيعمل ايه يا علي؟ بيعمل العكس. فين اللي انت قلته لي؟ اهو. فين اللي قلت لي دوس عليه بيرمننت؟ هي دي. طبعا حتى الايد السحريه ما اشتغلتش، يعني هو ورهاني هاو تو ورك. اهي اشتغل. هذا ماجيك طبعا. You can see here this area. This is what we call it notch. فwhen you have notch like that, وقلنا قبل كده ان النوتش not necessary to reach the rim. This is the notch. You can see this is the notch. خلاص all of us agree. And this is the corresponding nerve fiber layer analysis opposite to the notch. You can see here is better, very clear. And around, usually around the area of nerve fiber layer atrophy, you can see bright nerve fiber layer. Bright, it's very bright. In this area is dark. What about this slide? This is very long, very huge cupping. You can see the cup disc ratio is vertically taking almost all the disc. And this is the peripapillary region, beta zone is very large here. And opposite to that, you can see very bright, prominent vessels and atrophy of nerve fiber layers. Here also you can see, in spite of here, the notch is not prominent, is not clear seen. Sometimes you tell this is normal disc, but usually a small cup, the small disc sometimes have a cupping which is not too much large, but it is large for this small disc, and it can be an early notching with nerve fiber layer defect. Look to this slide. This is the striations. Here, another point when you have, I mentioned before, if you have diffuse atrophy, diffuse loss of striation, so you may miss the diagnosis of nerve fiber layer atrophy. Especially if the disc, like the disc in the right side, you can see this is almost total cupping, so there is diffuse atrophy, but you can see the prominent of the vessels. But on the other side, there is bright striations in a normal nerve fiber layer. Look to this slide. This is the normal in the right eye. You can see the bright striation of optic disc. See, this is very bright. This is what I mentioned when you see a baby or a child hyperopic, you will see very bright nerve fiber layer. Looks like he has papilledema. And the other slide, because there is diffuse nerve fiber layer analysis, you will not see any brightness, you will see a prominent vessels, but the disc itself shows that this is most likely glaucoma disc. See the brightness here and the atrophy in the opposite side. What about lamina cribrosa? This is enlarged pores of lamina cribrosa is another signs of glaucoma which is not pathognomonic, What about disc hemorrhage? Is disc hemorrhage is sign of glaucoma? No. Normally, any disc can get hemorrhage. Even some people, if he coughs severely, he may get disc hemorrhage. You cannot, disc hemorrhage by itself is not a sign of glaucoma. But when you combine disc hemorrhage with other criteria, as I mentioned, because disc hemorrhage is signs of ischemia, and it usually occur in a type of glaucoma called normal tension glaucoma. So you should have disc cupping, peripapillary atrophy, most likely there is notching in these cases, and if you look carefully, you may get this hemorrhage. Sometimes it's very difficult to detect the hemorrhage from your examination from the first time. Yani it is sometimes, but if you see patient came to you with normal disc and disc hemorrhage, this is normal, this is not a glaucoma. So disc hemorrhage is not pathognomonic for glaucoma. Usually the disc hemorrhage, when it appears in a glaucoma patient, it takes 2-3 months to 6 months to disappear. And if it is ischemic or progressing, usually the hemorrhage will appear again. You can see here the disc hemorrhage. And this is the notching. This is the cupping of the optic disc, vertically elongated. And usually it disappears up to 6 months, indicate glaucoma progression. So look to this slide. Normally, this slide here, what is this? Disc hemorrhage. And after 6 months, the hemorrhage is disappearing. Look to this slide. There is some hemorrhage here, and in this area. So detection of disc hemorrhage, it requires from you careful examination. And I am sure even for expert people, sometimes they miss the disc hemorrhage, which indicate that this patient is critically important to lower his intraocular pressure, important to take decision for him to go for glaucoma surgery. As I mentioned, if you can see here, the hemorrhage is very, and sometimes you miss it, very easy. This disc hemorrhage. And see, look to the other slide also. But presence of disc hemorrhage itself is not a sign of glaucoma. You should have another signs of disc changes, اللي هم ال5 rules اللي قلناهم. So if you look for this disc, isn't rule is not obeyed. Why isn't rule is not obeyed in this disc? احنا قلنا السوبيريور rim is thicker than inferior rim. هنا السوبيريور rim is أقل من الانفيريور rim. شايفين؟ فإن this disc isn't rule is broken, elongated vertical disc cupping ratio, and there is some sort of peripapillary atrophy. For all these can go with glaucoma. I mentioned before that a small disc with large cup sometimes indicated glaucoma. Usually small disc has a small cup, large disc has large cup. So if you see small disc, you should look carefully to the size of the cupping, because the size of cup is very large compared to this disc. Most likely this patient has glaucoma. You will ask me how I know this is small or large disc. I will tell you later on. So there is peripapillary halos here, as we can see. Narrowing of the arteriole, generalized nerve fiber layer atrophy. Large cup for a small disc is indicated that this is most likely a glaucoma patient. What about myopic fundus? This is our problem in glaucoma. Actually, it is very difficult even for experts to diagnose glaucoma in high myopic patients. Sometimes it's very difficult to delineate the cupping from the atrophy and the pallor of the optic disc. And sometimes it's very difficult even to evaluate the peripapillary atrophy. And in this situation, in high myopic patient, we are not depend only. This is the only situation we are not dependent on optic disc in our examination. We are depending on other factors: family history, intraocular pressures, diurnal variation, corneal thickness. So you take all measures, then you decide this patient is glaucoma or not. You can see the myopic here. Where is the cup margin and disc margin? Sometimes it's very difficult to delineate anything in this slide, and difficult to diagnose glaucoma in high myopic patient. See, this is the scleral ring with myopic atrophy, pallor of the optic disc, which is normal in myopic patient. So you should augment all other criteria of diagnosis of glaucoma in these conditions. We mentioned before that normal disc has, normal disc, a large disc has large cup. You can see here large disc, and this is the cupping. This disc we should investigate or not? This is my question now. لا, you should investigate يا ريان. Ryan, there is what we call it medico-legal issue, very important. You work but you don't see the problem you may face as a glaucoma man. This is, I am sure, this is physiological. Okay? But you should do the basic investigation for this patient. You can tell the patient this is large cup, but this is equal, as we mentioned here. Cupping is equal to the pallor. This is physiological. مع السلامة, go. No. You should do basic investigation for this patient and give him visit again after 1 year. Then you can tell him this is physiological. In spite of, I know that this is physiological cup. So in a large cup, you should do investigation for this disc. So most likely this is a physiological and a normal disc. Here, this what I mentioned, how to know this is a small disc or large disc. You know this aperture of direct ophthalmoscope? عارفين direct? Look for this aperture. This is usually the normal cup disc reach, normal disc size, and move it to the disc. Normal. You can see here, small, it is larger than the disc, and here it is less than the, so that one is the large disc. The other one is a small disc. So this is the way how to know large or small. Optic disc size also, when we measure with 90 lens, 78, whatever you have, there is some lenses increase the size, some lenses decrease the size. So average vertical diameter of optic disc is 1.8 millimeter, and the horizontal is 1.7 millimeter. And you can see here the small and the large disc. Small disc usually 1.5, large disc average is 2.2. What about the cup disc ratio here, asymmetry? This is another sign of glaucoma. This is another sign of glaucoma not written in the 5 rules we mentioned before. اتكلمنا عن الريم والكابينج والبيريبابيلاري اتروفي والنوتشنج. This is what we call asymmetry of cup. If you have a patient with normal cup in one eye and large cup in the other eye, this is what we call it, asymmetry or glaucoma suspect. So when you have one eye with large cup, one eye with normal cup or less cup, you should investigate this patient. You should do all investigation to rule out glaucoma. Here asymmetry also of optic disc. What about the progression in glaucoma? This is after 10 years. And this is again the importance of disc photography. This is very important to do disc photography or optus photo for patient first time he came to you. You can see here in this slide, look here, the cup disc ratio, and look here, it is enlarged. You can see enlarged vertical cup disc ratio. What about here? Look here to the kink of vessel. This is what I mentioned early in the lecture, that the looking is to the kink of the vessel is very important rather than to look to the pallor. You can see in this slide here, after 4 years, see the kink, and the vessel is kinked more. This is again importance of disc photography for your follow-up of the patient, not only to diagnose glaucoma, but to diagnose if the patient is progressed or not. You may modify the medication, you may take the patient for intervention. You can see also there is enlarged peripapillary atrophy area. What about here in this slide? This is the second pathognomonic sign of glaucoma, which is enlarged beta zone. بصوا the importance of disc photography again. Look here to peripapillary atrophy region, it increased after 5 years. What about here? After 5 months, appearance of localized nerve fiber layer analysis detected associated with notch holes. You can see here, if you look here to the vessel, it is embedded in the inferior rim. You can see the vessel in the rim. Now the vessel where? It became with the notch. So that means there is progression also in this case. Again, this indicates the importance of disc photography. You will not remember طبعا if you see the patient by yourself what will happen. Look here again, after 10 years, enlarged cupping. And also here you can see the nasal cup enlarged in this slide. See the nasal cupping? If you look in this area, there is no cupping or kinking of vessel here, but here the vessel is kinking more and the cupping and the ballur start to appear. So enlarged cup, enlarged bill area, the kinking increase, this indicates that the patient is progressed. Let us go for this first test. What about this disc? What do you think? Normal appearance of optic disc. Isn't rule is okay. There is no large cup, no peripapillary atrophy, no disc hemorrhage. Huh? Striation of optic nerve around, so most likely this is normal disc. What about this disc? There is something here you can see from the first spot. What? What else? Disc hemorrhage, is it? So when you have a disc, even if it appears normal with disc hemorrhage, احنا قلنا disc hemorrhage not pathognomonic. Look for other thing. Look for peripapillary atrophy. Look for cupping of the. Look for kinking of the vessels. So maybe this hemorrhage will let you look carefully for the optic disc to rule out glaucoma. يبقى disc hemorrhage isn't rule is not obeyed. So most likely is glaucoma. What about this disc? Look here, large disc, is it? This is large disc. And the cup also is large. The cupping equal to ballur, isn't rule is okay. So most likely here, most likely is normal. But again, I stress, when you have a large cup in a normal disc or large disc or small disc, better to make baseline investigation. Nobody will catch you later on if the patient came after 2 years with high IOP and more enlarged cupping. What about this disc? Very clear. You can see from the first spot that there is large cup disc ratio, vertical elongated, peripapillary atrophy, nasal shifting of the vessels. But this is very clear. Superior notching, nerve fiber layer loss, superior and inferior. But this is definitely glaucoma. Well, this is طبعا the typical picture we usually give it in all lectures about typical everything about glaucoma. You can see the disc hemorrhage, peripapillary atrophy, elongated vertical disc, cupping, everything, notching. But this is typically glaucoma disc. يعني you have more than one sign for diagnosis of glaucoma in this slide. What about this one? You can see the kink of vessel inferior here. That means there is inferior notching. And as I mentioned before, if you see notch, this is pathognomonic of glaucoma, then look again for the other criteria of the 5 rules we mentioned. What about here? Isn't rule is not obeyed also. Nasal cupping. See the nasal cupping here is very large nasal cupping here. And the inferior notching, so this is definitely glaucoma disc. What about this one? This is most likely normal disc again. What about this one? There is cupping here. You can see long elongated cup. The disc looks small, peripapillary atrophy. So even a small disc, you may miss a diagnosis of glaucoma. Take care in a small disc because you may look and tell this is normal disc. But when you look to other criteria of the kink of visual peripapillary atrophy, you may diagnose early glaucoma in a small disc. What about this one? Isn't true, is not obeyed again, peripapillary atrophy, notching, nasal and inferior. This is glaucoma disc. Clear? Any questions you have? تفضل. حق السمول ديسك اللي قبلها. What do you think? You mentioned there may be a notch in this slide. This is the kink of the vessel, normal kink of the vessel. Number two, you should, when you diagnose notch, you should look for other criteria. Oh, this is real notch or not. Look to the rim. I understand you mean this area, صح? Any other opinion of this slide? طبعا what we discuss the clinical impression of your diagnosis. If you suspect in this slide that this notch, what you will do? Number one, you look for other criteria of optic disc glaucoma. Any other criteria of glaucoma here? Look for nerve fiber layer opposite to this area. Is it pale or not? Look for disc hemorrhage. Look for peripapillary atrophy. There is any other criteria of glaucoma here? And this what we let us discuss what we call it anomalous disc. Sometimes you see a disc looks glaucoma, and when you investigate OCT, which is structural loss, you find it completely normal. Visual field is normal, intraocular pressure is normal. In this situation, if you see a disc looks like glaucoma, that's why always I mention most likely, except if it is clear notch. This is not clear notch. This is the normal kinking of the vessel in the cup border. But if you suspect, I am happy to tell that there is suspicion here. It is good for you. Look for any other suspicion in the disc. Any other 5 rules here? No. No problem. We can investigate, do OCT for this patient. It is within normal limits, so most likely this is normal. Sometimes it's very difficult. You see a disc and you tell this is glaucoma clinically, and when you investigate, you can find that all investigation normal. This is what we call it anomalous disc. So put in your mind that sometimes, عشان كده أنا قلت لك من الأول, even if you have very large cup in patient and you mention 100% physiological, you should do all investigation, basic investigation, to be even in safe side from medical point of view. Sorry, today we, for the other lecture not open, but I am happy that I have this lecture in my flash. Otherwise, no lecture today. Any other comments? Dr. Malik?
Very nice lecture, thank you, very comprehensive.
You have any comments? Do you have any advice for our colleagues, our friends?
Yeah, so look at the disc carefully.
Yes.
This art of looking at the disc has gone now. When I was a resident, if you called consultants to look at a disc and you didn't dilate the patient, you would get annoyed. So you have to dilate the patient, especially the first visit, have a good look at the disc, look at all the 5 signs of the Essam talks about, and then have a clinical impression even before you look at the clinical investigation.
Yeah, thank you. Unfortunately, other subspecialty, oculoplastic, I will not mention anterior segment, our colleague is here. They are not look to the disc, not carefully, just to take a fast look. And usually they have the intraocular pressure parented by air buff. صح? In the clinic. So it is not his problem. He is not looking carefully. This is not a defect in him. Not ما هيش مشكلة. But what I mean, you should look carefully to the optic disc. Especially if you work in glaucoma, should look carefully. If you suspect anything, we have many referrals from other subspecialty, our colleagues. They mention, I am not happy about this. Thank you very much. Then you should look carefully and investigate this disc is normal. At least to do the investigation before even you send the patient, OCT nerve fiber layer. If you are not depending on visual field, because usually the visual field appear late if this is glaucoma. Thank you. If any other comments? Anterior segment to trauma, sorry for lecture changed. Thank you very much. اتفضلي. دي حافظة ما شاء الله السلايدز يعني. هي دي. طبعا الكينك is very clear here. You can see the kinking of the vessel. طبعا السلايدز ما هيش قرآن يعني هتجيب لك exactly what you are saying the patient, but here may be clear for you that this is vertical elongated of the optic disc. You will not see the nerve fiber layer defect clearly here in this slide. But we are teaching when you see a king of vessel or notch, look carefully for the other criteria to diagnose glaucoma. We'll give you chance now to start. Thank you very much. See you inshallah next week. We'll try to prepare lecture in online before I come. Thank you.